Okay. So welcome everyone to Global Interdisciplinary Summit 2020, co-hosted by Global Outreach Medical and Health Association. I'm Dr. Gagandeep Kaur, I'm core member of GOMA. So I welcome you all for this session of the today. And with this, I will move on to, again, a power pack session by Dr. Amin, Dr. Ramsey Amin. So, speaking about him, Dr. Amin maintains an implant-only practice in Burbank, California. He also performs full-scope implantology such as bone grafting, revisions, and complex dental reconstructions, including zygomatic implants and nerve repositioning. He's a diplomate of the American Board of Oral Implantology, Implant Dentistry, and fellow of the American Academy of Implant Dentistry. Dr. Ramsey is also in the editorial board of Dentistry Today in the Implants Today subsection. Dr. Amin is heavily involved in the American Academy of Implant Dentistry. He was selected to be an officer of the Academy representing the Western United States. He also serves in the AAID Education Committee. He's founded the Education-Based Dental Implant Exchange Facebook group exclusively for dentists and dental lab technicians. In his free time, he enjoys fitness, skiing, family time with his wife, and others. So with this, I welcome Dr. Amin. So the stage is all yours, sir.
Thank you very much. Thanks for having me here. And it's a pleasure. Thanks for the opportunity. And that last lecture that we just had by Heidi was phenomenal. So it was incredible. So I'm coming off the heels of that. So I'm going to jump right into this. And the theme of my lecture, let me get the proper slides up here. It's interesting talking to nobody here, but hopefully we see you guys online. The theme of my lecture is leave no patient behind. So there are many times patients are told, hey, I can't be treated with implants. There's no option. I'm just stuck with dentures or no teeth in this segment. So I'm going to talk about some things that are a little bit different, that are unusual. Of course, zygomatic implants are getting a little bit mainstream, but we'll also talk about relocating the mental foramen on the mandible. So we're going to cover the maxilla and the mandible a bit, and hopefully wrap things up in about 40 minutes or so. I know everybody's tired. I think it's a death by webinar, right? It's we're certainly getting a lot of screen time. So let's jump right into this, and hopefully everything is working. Can you see my screen all right? Can I get some sort of feedback that screen is working? So I think so. So yeah, zygomatic implants.
It's visible.
Okay,
it's
perfect,
visible.
perfect. I don't know if I'm on the screen or not, but hello to everybody out there across the globe, and stay safe and stay home. I think it's the right thing to do for now. And so zygomatic implants, as we know, they engage the malar process. They've been around since 1988 and became more mainstream in the US about 1998, 2000 maybe. And the original versions of them were threaded from top to bottom. There was really only one manufacturer, that was Noble Biocare, Branamark at the time. And they had an external hex on them. Some of our newer iterations of these implants are smooth all the way through. They're machined surface, not polished, all the way down, and then have basically like a 16 millimeter regular implant on the end at the apex. So look at this, the transition. So zygomatic implants are often thought of being at a kind of a last ditch effort, and sometimes they are for a patient like this. I mean, look at that maxilla. It is just flat as a pancake. There is nothing there. That is her whole maxilla. That is what's left of an anterior nasal spine. All of that lip support is supported by denture base and denture flange. So it can be thought of, and it can be used for the very extreme patient. They're placed into the malar process here, and you can see not everybody is symmetrical from right to left. On the patient's left over there, you can see it's a different size than the one on the right. Their zygomatic process is completely different from side to side. So it's a small amount of real estate, and you can see the amount of resorption underneath the nose, that the piriform rim is basically even with the alveolar crest. There's really nothing there. These patients have no options. Again, small piece of real estate to land. That implant's supposed to land right in there somewhere, not in the zygomatic arch, but in the zygoma itself, in the zygoma proper. So these are just some sections of, let's go back a slide over here, of one patient on the right is a patient that I treated with a quad zygoma. This is immediate post-op, so you can see some fluid in the sinuses, but that's about where they end up. It's supposed to come right out the cortical border of the malar process itself. So, advantages are, we can it allows immediate load, which is just tremendous in today's day and age. We'll go through some options as well in sinus grafting, and you can increase AP spread, especially in the patient that has like a square arch form. If their jaw is very square and you put in 4 implants, and you don't have enough AP, by adding zygomatics and or pterygoids, you can add a lot of AP spread on. And Dan Holtzclaw did a great lecture yesterday on pterygoids, and I'll touch on that a little bit. To me, the zygomatics and pterygoids go together like peanut butter and jelly. In America, this is certainly a staple of ours, and I think that's what's for dinner tonight, to be honest. So, and especially when the sinus comes really far forward, it allows for a concept which I call remote anchorage. Placing implants into good bone rather than rebuilding the bone that a patient has lost already. And to me, it's not first-line treatment. It certainly other options need to be exhausted first. Obviously, it's a more invasive concept than just a traditional all-on-4. But the reality is the zygomatic is probably going to be the bailout for our failed all-on-4s, and there's a lot of them. There's a big wave coming of failed cases that are just they're going to need retreatment, because dental implants are not forever, right? They're certainly not. So please don't promise, permanent solution unless your patient is maybe 75 plus. And most of the guides out there, with the exception of probably one made by Norris Medical, are not that accurate. So there is potential for significant damage of your patients. This is not to be taken lightly. And they're kind of like flagpoles, right? So they're just anchored at the very apex, and then they swing on the end. So they require cross-arch stabilization for them to be able to work. Disadvantages, I'm sorry, this is basic for some people, but there's increased risk, technically difficult. And it's very difficult to tell if you have a failed zygoma, right? You can't really take a pano, or you certainly can't take a PA up there to see if it's healthy. If there's chronic sinusitis can be a problem, especially if you've placed a zygomatic on a patient that does not have a healthy osteometal complex, not only patent but not narrowed, and healthy ciliary flow. And again, if they're in the old days, we used to position them on the palate, and that really gave them a bad name. They were difficult to restore, difficult for patients, and would obtain their ability to speak even. And again, not first line, in my book at least. So there's this thing called the Zaga classification, which really just tells the shape of the lateral wall. And it's basically type 0 through type 4. Carlos Aparicio was the developer of this particular classification method. And what it tells you basically is the implant. There's a lot of different terminology: extra maxillary, extra sinus. So basically, depending on the shape of the lateral wall, a zygomatic implant may be completely in the confines of the sinus, or it may be completely out of, like on a type 4, which we don't see too often. Those are the most difficult of all, where just the apex is engaged, and there's not a lot of support on the crest at all. So we want to get crestal support and zygomatic, really a 2-point support. You can actually engage multiple cortices, up to 4 cortices when placing a zygomatic implant, depending on the patient's anatomy. So quad cortically stabilized implant on some patients, but at least 2 of them. So, and we could talk about the classifications and the lateral walls as well, but we also see a difference in thickness of the zygomatic bone. I certainly would not want to treat the patient on the left. There's hardly anything there, right? There's maybe, in an oblique pattern, maybe we'll gain 6 or 7 millimeters of apical engagement, whereas the patient on the right's got really chunky zygomatic arches. So let's go through kind of the typical patient that's got a really resorbed maxilla. She takes her denture out, and there's just nothing there, right? Again, the flange just supports it. So the alveolus has been lost in every direction possible. And again, this is the same patient. I will show some of the surgical pictures of this patient, kind of take you through the workup, but not a lot of options. Either wear denture forever or zygomatic implants, zygomatic and pterygoid. So in this patient, you can see the massive AP spread that's gained. So 4 zygomatic implants are placed in the quad zygoma concept. And you can see that these implants, this is about in the almost lateral incisor position, definitely canine lateral incisor. And there's a lot of spread. I like the implants to spread apart as far as possible to gain that. I see a lot of zygomatics placed very closely together like so, if we can get apical engagement, but then that gets the apices. Wide AP spread does get the apex close to each other. The quad zygoma is certainly the most difficult of all. And if pterygoids can be added to it, great. Not all patients have pterygoid bone, and sometimes you are left with the option for only a quad zygoma. And you can see the AP spread, and it allows for immediate loading. These cases, typically same day or next day, will deliver a fixed prosthesis. So the patient goes from maybe not having teeth for 30 years into a patient that now has a fixed prosthetic within a few hours. So really is quite an amazing thing. And this is how this case ended up restored. Over here, we'll talk about complications a little bit, soft tissue dehiscence right there. You can see a little bit of the implant showing there. This is upper and lower zirconia done by my lab technician, John Wilson. And these patients, these restorations are a little bit more difficult to contour, to be able to, because you're replacing not only just the teeth, but obviously the bone, the facial structure. These patients need to learn how to speak again as well. So again, this is leaving no patient behind. This is how these cases end up, and Zirc over Zirc, and patient's really happy. So I'm looking for comments along the way here, seeing that some friends are online. I've got my phone down here, but this is what it feels like sometimes, just like a big giant drill, headed in this direction. Certainly you want to get adequate training to be able to do this and not just jump right out there. So let's look at this patient from start to finish here, or at least along the way. There's not a lot of time to do start to finish, but this patient's we've got a failing mandibular dentition, and also her maxilla is hollow. You can see she's had combination syndrome, and her anterior maxilla has just been pounded on by these remaining lower teeth for so long. And there's nothing left. There's no bone in zone 1, zone 2, or zone 3. And there really isn't any pterygoid bone here as well, at least on panoramic. So we'll look at this. Let's see if hopefully this video will play. Kind of get an idea of how this works here. There's a delay on my end, so I'll just be quiet for a moment. And you can see the AP spread that's brought out over here. The retractor is placed in the frontozygomatic notch all the way up on the side over here. It's got to be up by almost by the temple, it feels like. Lots of irrigation. And those implants, they get close to each other at the apex. And I'll show you the final x-ray. It'll look like they're crossing each other, but the reality is they're not. They're just close like so. Hard to see on the screen. And you can get some very high torque. High torque is sometimes too much torque and can fracture the zygomatic process, which is not a good thing. Fracture the buccal wall, similar to fracturing a buccal wall on a maxillary anterior placement. So that's the immediate post-op the next day after delivering the interim prosthetic, and she went from basically no teeth to fixed teeth, and that's how this case ended up restoring. And patient is super happy. She's got a full complement of teeth, and she can eat what she wants. She was told for years, she had been exploring having her mouth restored for years, and no options were available to her at the time. This is another patient, kind of similar maxilla, pretty hollow. Of course, no time to go through a CBCT. these cases are always more difficult when there's lower teeth present. So obviously the lower teeth are going to stay, but there's just not enough angulation. The mouth has to be able to open very wide because the drills are coming at a really extreme angle. So the lower teeth are always a problem when we talk about placement of these. So after a full maxillary flap, and we can see that this patient's got very little bone. That's after no alveoloplasty at all. And this is going to be like a Zyga 3, Zyga 4 type of case. Very difficult to gain stability in here. And this is the primary assessment here on the CBCT of my plan. And this is how this worked out. Yes, it's an interesting image. Everybody's eyes are going over to this one over here. I did not have a lot of torque on these cases, right? So I've promised this patient immediate load provisional, and I can't fit pterygoids into, or at least I thought I couldn't at the time. And so I took some titanium mesh and actually strapped it down, and it did great. You know, some prayers and hope that it works out. And this is what it looked like after she left that day. And you can see the massive AP spread. I've got this, I think, almost crossing the arch. Those are 55 millimeters with 52 degree multi-units. And there you can see a little bit of the tie mesh over there. So the case was loaded immediately. If I were to abort on this implant, then patient has no option of having her immediate provisional at the time. So it's either get all four stable or you wear a denture. There's no real option. So this is what she looked like. I actually just converted her own denture. She was happy with it. You could see the AP spread on it, definitely into the centrals. So this is a few months later. Tissue management is really important here, that you get all the keratinized gingiva on the facial that you can. Patient was completely asymptomatic. This is the one that had that titanium mesh holding it in. Well, guess what? It fell out. Didn't take. I went to torque it and it moved. And that's what I'm saying with the zygomatic implants. You really can't tell if they're failing or not. Patient had no pain, no sensitivity, nothing. I torqued it, it fell out. We were changing her over to a PMMA, took out the zygomatic, placed an immediate pterygoid with a multi-unit abutment, and carried on with a digital impression. Yes, you know, this is a massive space between pontics, but the goal of this was, you know, I said, leave no patient behind, right? I can't just let her go with nothing. I'm going to come back and maybe replace the zygomatic later on, but at least I left the titanium mesh in, but at least she has teeth the entire time. There was not, she was never just bailed out on. She was worried. She was crying. What am I going to do? I can't wear the denture. Well, there's always solutions for these patients. And the pterygoids, they're very difficult to restore. Again, kind of piggybacking on Dr. Dan Holtzklaw's lecture yesterday. Interarch space is always tight on these cases. So certainly be sure you have enough room to restore these cases. They can get very tight. And that was the how this case kind of worked out. A lot of buccal gingiva on the outside, even though the multi-unit shows, that's okay. There's a lot of tissue around those 52-degree multi-unit abutments. And you can use them in a variety of ways. They don't always have to be placed bilaterally. As long as they are cross-arch stabilized, you can link one to the other. Here's a case where I had some sinus bone over here. Instead of doing a quad, I placed 2 implants over there. Here's a patient where only 1 pterygoid fit. And we'll make an asymmetric restoration. I know, Nick, you had asked that question, I think, yesterday. Here's another patient I treated that, why zygomatics on this case? Not that atrophic, right? You could probably put some regular implants on. Got a really square-shaped arch, and it was very important that this patient was guaranteed that he could have an immediate provisional done and not leave without teeth. A very high-profile patient, and needed to be sure. So in his case, the zygoma was the way to go for this particular situation. A backup plan was not an option of not having something fixed. And there was a major perio condition, this is the same patient, to correct, and some major occlusal plane corrections to do. This is the final zirconia over zirconia. But again, this patient never was with a denture, which oftentimes causes complications, right? So this patient explored options for treatment, and he couldn't find he couldn't get a satisfied answer was how he was going to go without teeth, because everybody wanted to remove his teeth first, which I would not fault at all, and then transition him through a denture, and then maybe some implants, he was told. So in his case, the Zygomatic helped guarantee it. This is a patient that came to my practice with a, all on four, failing all on four, right? That's a beautiful all on four, in my opinion. That thing lasted like 20 some years, apparently. There are 4 natural teeth. Although I don't advocate this type of treatment, it's amazing that it lasted as long as it did. And obviously it's falling out. Patient would like a full complement of teeth. And you can see there is very little bone here, very little in the pterygoids. We've got an apical infection or lucency around the second molar. Sinuses are very anterior. And if you saw the cone beam on this patient, you'd see that there's nothing present over here. John, this is the patient you and I may go through on a different lecture, actually. So this is how the case ended up. Why 7 implants? Because that bone was like butter. It was just super soft, not a lot to grab onto. Multiple place implants in remote anchorage into the nose, into the pterygoids, into the zygoma, and a very difficult case because you can see even where I had to, I'm aiming for crestal support on this zygo. So you can see I'm scooting a little bit to the lingual so that it doesn't just hang off the edge, so that it's resting on something. This was not my attempt of doing a sinus lift. This is actually the zygomatic implant just resting on the zygo there, on the crest. And there's the 2 pterygoids in the back as well. So several months later, fast forward, of course, several appointments later, we've got some good attached tissue everywhere. It's always a bit thin in the pterygoid area on some cases, and a little bit lingual, but hey, that's okay. It's doing great. I'm happy with it. Here's how the case ended up. And we've got a convex or flat intaglio, multi-unit abutments, and also, it's very cleansable, very aesthetic, and a patient has second molar occlusion. So this was, leave no patient behind. And she was told there was no option. This patient traveled about 2,000 miles to see me for this treatment. And this is how the case ended up. I'm going to move this along a little bit because I know everybody's tired of watching webinars. So here's another patient, right? Kind of similar situation where, severe perio, right? It's a young patient, 30, late 30s, at best 36, 37 years old. The sinus carries forward much further on the left side than it does on the right. So remember that severe perio, young woman can't go without her teeth all this time. And, you can see all the implants were placed, the teeth were removed, and I needed 1 zygomatic on that side, just so I had rock solid support. You can see it, can't really tell, but I'm kind of torquing and pushing, and it's getting, it's going to be a solid stop. I feel very comfortable with immediate loading on this patient. Hopefully these videos are coming through and they're working. So again, a unilateral case, tilted concept, axial concept on the lower, and a unilateral zygo. Yes, I could have eliminated the cantilever altogether, but that puts me more in an orbital position, right? So the further posterior you go, the closer to the eye that you become. So cantilevering 1 tooth is really not a problem. And you can see what a tremendous change on this patient from severe perio to, just a nice, happy smile. So it's nice to see. It always makes my day when I see her in the office. And just a tremendous change, difficult case, high lip line, and just a life changer. Never had to wear denture. So why the zygo in this case? Because it gave her the opportunity to guarantee an immediate load. Because the other options are, here's another patient I treated, and I love bilateral sinus lifting. It's a lot of fun. This is a difficult patient with a short ramus. No bone in the maxilla, just, did not consent to doing zygomatics. And this was the option, 12 to 18 months, wear a denture or wear nothing at all. As opposed to, look at these, these 2 different concepts over here. And I see a lot of friends here online. Thanks for joining. I'm watching here on my phone. Appreciate all of you guys in here. So, the 2 very different concepts. I think I've got a 22 or 25 millimeter. I do agree with Dan, if you're there, I do agree with you. Most of the time, my average is probably 20, but occasionally I get to sneak one of these really long ones in, and it looks kind of cool. But remember, those 2 implants are going not like so, but they're going 2 opposite directions, pterygoid and zygomatic, even though they look like they might parallel each other. One patient got teeth on the same day on the left. The other patient had you know, 18 months of treatment and quite a lot of expense, to be honest, to do that. Another patient kind of treated the same concept. Zygopterygoid, like I said, they go together like peanut butter and jelly. Let's talk about some complications here. I want to move this along as everybody's webinared out. I know I sure am. And soft tissue dehiscence. You know, this patient, I can tell you that the tissue above this zygo looked just the same as all of the rest. But because they're, you know, let's say out of the alveolus, I try to keep them within the confines of the alveolus if possible. Oftentimes you do get the soft tissue dehiscence. So some of the designs that have a machined neck or machined collar are going to do better long term. And you know, the key to these is treatment. This is a much older case from many years ago. This is a Brandemark case that I placed. Is mobilizing buccal fat pad. We found that when the buccal fat pad is mobilized, and you can pull it forward even up to the central incisors, that it does protect the facial aspect of the zygomatic implant. And this technique really is something necessary you need to master in order to place these types of implants. There certainly is more risk in all of these procedures. There is a lot of anatomy that is very vital in this area. But again, covering the zygomatic implants with buccal fat pad is always the case. This is there's a hidden implant over here. This is a typical all-on-6 in my office. And you can see that where I'm covering this one, I'm going to cover both anyway, but this implant's a little bit more out of the housing, where this one's more tucked in. It simply has to do with the patient's anatomy. These are not my slides, but you know, off a journal article, obviously complications, nobody wants to end up in the eye. You can see up here, I'm going to try to get this to annotate better. Give me a second here, we'll try something fancy. That looks better. Okay, so up in here, you can see that, you know, obviously the implant entered the orbit, and that's a major complication. Even if it gets super close, there are muscles around the eye that can become damaged, and the patient will not be able to move their eye properly. So complications that everybody is kind of aware of, but nobody wants to ever see. But they do happen. Again, this is from a journal article. It's just hard to look at that image, seeing damage to the patient's eye. That is really just too close over there. Other complications will be like, well, here's a patient that, you know, can't blink her eye, right? It's a patient of mine. Here's the infraorbital nerve over here. And, you know, so what's going on over there? Any number of things. There are some extra foramina that that go between the malar process and the eye. They may anastomose branches of cranial nerve 7, the facial nerve, which is a motor nerve, in addition to anastomosing with the sensory nerve of V3 coming out from the eye. So you have some from the outside, some from the inside that can cause some of those issues as well. I'm gonna turn off that spotlight thing, I'm sorry. Hard to do if you've never hosted a webinar before. It's not easy. Let's keep going here. Let's talk about, well, when they fail. This is like this here. I'm going to show my failures right in front of the globe. Let's show some failures here. So this patient had no symptoms at all, and I took off the interim prosthesis to start with the final, and it started moving on me. So I figured, well, hey, let's just record this for the world to see. So when the zygomatic implant fails, this is how easy it comes out if it lost integration. I'll just be quiet here for a second. It takes all of about 5 seconds to get it out. Very successful implant, but it's important to show, you know, failure at times as well, right? Sorry, I'm going to skip slides here. Other complications, somebody can have a cutaneous fistula on the outside, or the implant could be overextended and require sometimes a skin incision from the outside to deal with, or do an apicoectomy on the implant on the outside as well. So, you know, which one has more risk, right, in treating the atrophic maxilla? Double quad zygoma with or without bone grafting, or without bone grafting, or doing full arch block grafts and sinus elevation, right? Either way, you've got to enter the sinus. And that's really a personal decision. Again, I like both, but that's a lot to put a patient through full arch block grafting to have a fixed prosthetic and sinus lift, because they can't wear an interim prosthesis at all. They have no denture at all for all this time. I'm going to move forward here. This is where I practice. This is in Burbank, California. That's my office building over there, and that's what it looks like at night. Sometimes there's some late night here. It's doing charts, so that's my town. Let's talk about, we're talking again, leave no patient behind, right? Let's talk about mental foramen relocation, right? So we all know, we all get in the situation where we don't have any bone in the posterior mandible, right? We have a lot of options in the posterior mandible, but sometimes that nerve is just sitting on the crest. So there are times that you can move the mental foramen, reposition the nerve. Let's go through a few scenarios. And again, this is really a procedure that's reserved. It's not a procedure I do every day in my practice. I've done it for about 16, 17 years now. And it's really reserved for patients that want teeth at all expense, right? I want fixed teeth. I'm willing to assume the risk of this procedure as well. So let's talk about some, basic anatomy, right? And some indications for this. So, if the nerve is shallow, or if the foramen is just in a terrible position, it may be an indication to move the mental foramen. If you're not able to do vertical augmentation, not because of your skill set, some patients just aren't good candidates for vertical augmentation. It can be contraindicated. Moving the mental foramen is also useful on patients that have poor AP spread, where you have a very square-shaped jaw and you can place the implants as far back as you want, and you still don't get a lot of spread. So I'll show you one patient where we move the nerve just to gain some more spread. And it's an alternative. So some patients are missing teeth just on both sides, and some practitioners will say, I'll just take out the remaining lower teeth and just do an all-on-4 and be done. Well, are you creating a dental cripple from that, right? It's possible. So maybe just move the nerve on both sides and do that. So let's go through there's two basically schools of thoughts on this. One is relocating, repositioning. The other side is lateralization. So when you lateralize the nerve, you're preserving the incisive nerve, right? So right at the mental foramen, you have the inferior alveolar comes in, and then it branches off to the incisive. So it gets preserved when you lateralize, but it's tethered. So if you're just going to move it out of the way, you have to stretch it, and you have to put in the implants on the same appointment, right? So it's tethered the whole time. You don't release it. On the relocation, reposition, the mental foramen is completely distalized from this area all the way back to about the second molar, and there's no tether. So once it's detached, it can be freely put wherever you need, and I just leave it in the cheek when I'm done. It is a little bit more invasive, and I'll show you a video on this, but their anatomy is altered forever. So their mental foramen is no longer where you learned it in dental school. Let's take you through a patient over here, where this patient is missing this segment of teeth. And, I can't build her vertically anymore, right? What is that going to do? Just close down her inner arch space, maybe open her vertical dimension. Wasn't really needed on this case. And that's an 8 millimeter implant you're seeing on the side over there. Not a lot of room above the nerve. Certainly some short implants can work with Morse taper connections, are great. So on this patient, I simply will just take out the inferior alveolar nerve. There you can see it looped in a, that's called a vessel loop, which that blue is tagging it. And this is one side, and this is the other side, where you can see that the mental foramen, I'm hoping, let me turn on that little annotate thing here. There it is. So you can see where the nerve comes through. Sorry, it's red. I don't think you can change the color of this thing. The inferior alveolar nerve comes through, and it's attached. Here it's tethered to the soft tissue. So the incisive nerve was cut over here, then the mandibular nerve comes out and then branches into the nerve that gives sensation to the lips over here. So you do, that's what I mean by tethered. There is a stump here that is purposely cut. I'll turn off spotlight and we'll carry on. Excuse me here, sorry. Getting harder to do these things than you would imagine, talking to yourself. So this case is quite old. You can see it's restored with PFMs. Did this case many years ago. And on that upper left part of your screen, you can see where the mental foramen is now. It's completely distalized back where that wisdom tooth is. That's where the arrow is located there. And it is now, you can't even see even much of a remnant of where the inferior alveolar nerve was even present before. This case was made more difficult by the fact that she had molars here in this area. Would have been a lot easier if those weren't there. But again, this is leave no patient behind. Sure, I could have used possibly some very short implants, but I've got some really great engagement almost to the inferior border. I don't think you need to grab the inferior border. How about this patient? You know, she spent her life savings trying to, you know, correct her facial aesthetics. She had some sleep apnea. She underwent double jaw orthodontic surgery, had some complications on this side where the mandible was put together a little bit in a funny way. And her nerve anatomy was just very strange. You can even see some remnants of the sagittal split osteotomy over here. She even after that, she has almost no paresthesia at all. And she was told no way to have implants over here. That's not the nerve over here. That's the nerve up over here. And I'll show you on a little video here. Let's hope that this runs. I'm hoping all the videos are running in here and working for everybody, that I'm not just talking to myself. That would be kind of funny though, right? So we can see here that those are, I believe it's like 11.5 implant and a 10 millimeter implant. That's the plan. Look at her mandible. It's like the size of my finger. It's just tiny over here. Her mental foramen was right out here in the front by the apex of this tooth. Really just a terrible position. So I think I have a video on this patient here. Let's go into that. I'm going to try to skip forward into here. This is what it looks like when I started the case. Her mental foramen is in a very strange location. It's basically hugging up against the tooth over here. So it's a big surgical flap from basically midline to the retromolar area. And this video should run over here. It's about 2 minutes long. I'm going to try to narrate this along the way. I'm hoping that you can hear my voice as well. So the mental nerve is, I'm sorry, I'm making an osteotomy here. It's going pretty fast. It's like 7x speed. I'm not that fast, actually. I've looped around the nerve with my vessel loop. I'm protecting it. This is done with a piezoelectric device. I'm making a channel across the whole mandible with piezoelectric, and I'm cutting an osteotomy around the mental foramen as well. You're going to see me use a straight elevator there. I'm going to remove pieces of bone until I can get all of those little chunks of bone that make a cortical rim around the base of the implant, base of the nerve. So again, you've got to work very closely and just diligently. This patient's nerve anatomy is just very close. Here comes that big chunk. That's the osteotomy taken off the side. I'll end up putting that back later. And the nerve is going to start to show up. I'll take the ball tip of my piezoelectric unit and begin to just kind of dissect around and behind the nerve, freeing it up the whole time. Once I'm certain, so here I'm in the loop area. Once I'm certain I've identified the incisive nerve, you can see the nerve coming out. You can see the whole mandibular nerve coming out. Once I'm sure I've identified it, I actually cut the incisive nerve, leaving the mandibular nerve tethered to the mental nerve, which leaves the patient with complete sensation to this area. They may lose some sensation in the teeth, but there's the nerve over there. It's amazing that any of us ever miss it on a nerve block. It's so big, but we all do it, don't we? We all miss that nerve block and wonder if our anesthetic got switched out to water. Maybe after COVID, it's all going to be expired and nothing's going to work, and we're going to wish we were back watching Netflix at home again. So there's the nerve out there. This patient, I typically don't place implants simultaneously. Sometimes I will. I hope that video is coming through at a good pace here. I'm going to skip forward. Again, there's always a delay with these Zoom conferences. And here we can see a few months later, place the implants over here, 11.5s, I think, on the posterior and a 13 up in the front. And this patient will end up having a fixed prosthesis. Here's another patient that is a very unusual situation. This case would have been a lot easier to treat without moving the nerve and just done some maybe a cantilever. This patient's an engineer, doesn't want anything like that. The implants were restored by another colleague, and they aren't not doing that well, but over contoured, etc. He did not want to grind this tooth on. He didn't want to take off these implants. He didn't want to do anything with it, but you could see the defect is sitting here on the left of the screen, right on the top of the nerve here. So even if you did do some reconstruction here, maybe you might gain a little bit of height over here. It's possible. In his engineering mind, he wanted a very long implant. This is what it looked like over here before some tissue augmentation. So just move the metal foramen. And on his case, I placed the implant simultaneously. I think I placed a 16 just because it just kind of looks neat when you place a implant. You use the whole body of the mandible. You could even go longer if you wanted to. It doesn't really gain a whole lot. You gain more surface area from width than you do from length. But again, this is where the mental foramen used to be, right here outlined. And here we've got a single tooth restoration, leaving the other teeth untouched, and it should do fine over time. Again, leave no patient behind is the theme here. Here's the metal foramen on this really atrophic patient. And those are on the crest. Those, we can just move them, slide them back fairly easily, gain room for a fifth implant, just distalize it completely. And that gives more room for a full, either another implant or tilted concept. Here's another patient where you can see, this is just the cone beam here. You can see where the new mental foramen has reformed over here. I'm sure the radiologists like Heidi would go nuts seeing this kind of stuff. This is an older case or was being restored at the time. But again, this is what this looks like. You can kind of see again the stump over here. These are just multiple images on different cases where you can see the stump where I cut it and I've preserved. This is the part going into the lip. This is the part going back, to the brain, if you want to call it that, right? But again, vertical augmentation, Corey plates, and all different types of augmentations can work as well, or a lateralization can work in combination with it. So everybody wants to know, how long is the patient numb? Almost every patient I treat, I've never had a patient that has not had full recovery, but they all have some degree of paresthesia, usually lasting 1 to 3 months. The lower anterior teeth are going to feel a little bit wooden if they have teeth present. They're going to feel different because they've lost some of their vitality, but they will get some collateral circulation. Never had a tooth die from it either. And people have asked a question about what happens to the end of the nerve when you cut this incisive canal. This is where the cut happens at approximately E, or ideally between E and F. Do you get that Wallerian degeneration or pain or dysesthesia? I have yet to experience that at all. And again, we're going to wrap this up soon. I don't want to keep everybody here all day. But again, which has more risk, right? Do you reposition the nerve and the patient can bounce back and have just 1 or 2 surgical procedures? Or do you go through posterior mandibular augmentations and possible dehiscence and some vertical cases don't always work out. Even in the best of hands, there are still problems. Sometimes we see all this wonderful bone regenerated on these cases, only to see it 3 to 5, 7. I think 7 years is the magic number where we see the that bone melt away, especially some of the GBR techniques, heavily particulate without a lot of autogenous bone. See a lot of those cases, fail over time. And, some patients need all options. This was a patient I treated some time ago that was just atrophic everywhere, very straight, what's that called? Hemimandibular microsomia, I guess, on her right side. We can see that I had to lateralize her nerve on the right, zygomatics, pterygoids, a little bit of a mixture of everything. The other option would have been subperiosteal in the lower jaw, but this patient kind of needed it all. I've never had one patient that was all in one type of patient that needed, leave no patient behind. She was told there was no options, and there certainly are options. These are extreme options. Again, I don't advocate them on a regular basis. This is certainly a little bit off the cuff, but I think it's useful to know that this exists. And I'm going to keep it short and sweet here. I don't know how long I was. It felt like it was about 30 or 40 minutes. That's going to do it for me. Thank you so much. I really appreciate the opportunity to present in front of this audience here. It's been a good time here sitting in my office by myself. I'm hoping that somebody gained some knowledge out of this, and I appreciate you. Thank you so much. Are we there?
Yes, sir.
Are we okay on time? Was I too fast or too slow, or?
No, that was quite perfect, actually.
Okay, great.
Yeah, so thank you so much, sir, for the beautiful oration you gave and great cases you've shown. I was quite amazed, seeing all those, like, perfectly you were just playing with that nerve and, quite securing it. It was quite wonderful.
You have to
Seriously.
Yeah, you have to play with it and make it fun, right? It makes you sweat some more.
That was looking a bit dangerous, but yeah, still you handled it well. Okay, so we have, I think, a bit of questions to answer.
Okay.
Yeah. One from Dr. Saurav. Zygomatic implants placement always under local or general anesthesia? Please explain what complications we can face while placement in local anesthesia.
I've never placed a zygomatic under local anesthesia, and I would not suggest it. I think the patient needs some sort of, my cases are done under IV moderate sedation with a narcotic. There is, even though you need to do local anesthesia on the outside of the face, there are times where the patient still can feel all of what you are doing. And a narcotic certainly helps with that somnolence and your patient being able to not care that they have a retractor sitting right there, and really to get them through a tough procedure. I know that some dentists advocate full general anesthesia, especially on a quad zygoma, since you do need to be up really high up near the orbit. But all my cases are done under IV moderate sedation, your typical midazolam, Versed, and fentanyl in my cases, but I would not advocate it under local anesthesia. Although I know it can be done, I don't have that experience.
Okay, definitely. Next we have from Dr. Rava. How do you determine the length of the implant?
The length of that's a great question. So the length of the implant, it's not, you can, on your CBCT, you can estimate, you might end up, most of the implants are probably 42.5 is about the average. But depending on 1, 2, 3 degrees of angulation will change the length tremendously. So you need to have an inventory of implants that can change with you. Even though you've planned for a 45, you might end up putting a 47 or a 42 or even a 40. The way that you actually measure it is unlike a regular implant. When you're placing the drill over here, you actually see your retractor sitting over here, and you see the apex of your drill poke through the outer cortical wall of the malar process. Once you know you're through, there's a little instrument that has a hook on the end. It's like a depth gauge, and you grab that hook and you can measure the appropriate length for the zygomatic implant based on how tall your multi-unit is as well. You have to take your multi-unit abutment into account as well. But it's a direct measurement by sight.
Okay, thank you. And then we have from Dr. David. On that lateral positioning with that long implant, what about the IA? Is it lingual time the IA?
I don't really understand the question completely, but what I'm saying is, so the inferior alveolar is in the cheek now. So I've taken it out, I've untethered it, and I've just distalized it backwards. It's in the cheek. The mental foramen will basically get a new cortical border around it, and it'll end up just more distal than it started off with. So the IA is fully intact.
I hope the answer is quite clear to him. Okay, next we have from Rava again, Dr. Rava again. What type of prosthesis do you prefer?
Well, I don't know in what the context, but everything I tend to do is a fixed prosthesis, usually titanium custom abutment with a zirconia crown or full zirconia monolithic bridges for the upper jaw on those cases. That's been my go-to. I think it's a premium material when done correctly with good lab. That is my choice. Always fixed.
Yeah. Okay. Next we have from Dr. Roberto. Is there any risk of lower lip movement alteration during lateralization of inferior alveolar nerve?
So a great question. So remember that in your anatomy that the cranial nerve, trigeminal nerve V3, right, is a sensory nerve only, correct? So it does not actually, motor function comes from cranial nerve 7, which is, kind of sits on your
Patient,
face
yes.
like so and gives you the ability to move teeth. But if you do get a paresthesia, some patients that get paresthesia can feel like they get a little bit of drooping because they can't feel it as well. But they're two different nerves. So.
Okay. Next from Dr. Anish. Did facial nerve complication resolve?
Did what? Whose complication?
Facial nerve complication.
Facial, yes, it did. By the next day, actually. By the next day.
Okay.
Actually, within about 12 hours, correct. You're talking about the patient with the blinking eye problem, where their eye couldn't open and close. Yeah, that'll get you lose a night of sleep right there, right?
Okay.
Yeah.
Yeah, with this, we are over with the questionnaire. We're not
Okay.
having more questions. Yes.
Excellent.
So it was actually quite an enlightening lecture. So,
Thank you.
and
Thank you so
you
much.
have kept us amazed seeing those cases, and damn it, they were actually.
That's funny. I admire that you're here on every webinar and you're able to manage all this. You guys have done a great job without a lot of tech issues at all. So again, thank you for having me on this.
Thank you, sir. Thank you so much. So for the participants, stay tuned for more other interesting lectures like these and interesting speakers as of now. So thank you, sir, for the session. And with this, we'll move on to the end.
Thank you.
Thank you, sir. Stay safe.
You too. Yes, stay home for a while.
Thank you, sir.
Take care. Bye-bye.
Bye.